Welcome everyone to today's webinar. My name is Dr. Stephanie McCoy, and I manage Susan G. Komen's qualitative research portfolio out of our Center for Applied Research. I have the honor today of representing the NBCA Alliance, the NBCA, where all of us are coming together as members, including industry partners, nonprofit partners, and individuals to share a new collaborative effort and four-part speaker series called Changing the Conversation on Palliative Care. Today's topic is breaking down barriers and addressing pain management. Before I introduce our moderator, Stephanie Walker, to introduce our guest speaker, I have a few housekeeping items. Number one, we want today's webinar to be interactive, so we encourage you to put your questions in the Q&A box during the event. Please strive to keep questions general, as the speakers cannot provide any medical advice on a personal level. We also have received many questions ahead of time from the community that we will address after our guest speaker's presentation. Number two, we will be recording this presentation, which can be viewed in a few days on the NBCA website. At this time, I'd like to welcome my co-host for this evening, Stephanie Walker and Talisa Shepard, to share some background on why we're doing today's webinar and also to provide the patient perspective. Stephanie, I'm passing it to you first.
Welcome, everyone. My name is Stephanie Walker. I am a patient advocate, and I'm also living with metastatic breast cancer. I am one of the leads for the Black Women Speak Series initiative. The goal of the Speaker Initiative is to inform and empower women living with MBC. The goal of the Metastatic Breast Cancer Alliance Become Research Survey was to increase Black patient enrollment in clinical trials. The conversation was not being had between the medical providers and the patients. So Black Women Speak came along to provide the healthcare providers some tools on how to have that conversation with us living with MBC. Today, following that initiative, the conversation about palliative care also is another link in this chain that is not being discussed with Black patients. Let's talk about palliative care and the barriers facing some Black patients with MBC. One of those patients affected by this is Talisa Shepard. Let's hear from her.
Hello, everyone. I'm Talisa Shepard, and I am a 25-year breast cancer survivor. And of those 25 years, I've been metastatic for 22 years, with metastasis to my bones, lungs, liver, spine, abdomen, and brain. I've been no evidence of active disease since 2003. Some of the areas and experiences around pain management that I have experienced is just not knowing about the resources. Years ago, I didn't realize that there were resources for pain management. I didn't know what palliative care was. And I just wasn't told about this during my initial treatments. And I am a firm believer right now through my experiences that this is something that should be done up front. Have that conversation with your medical team. I didn't even know where to start looking for pain management help. Just lack of knowledge. And I really didn't even know what to ask for at the time, is what it all boils down to. You are faced with a cancer diagnosis at a young age, at any age, and everything is a little fuzzy already. Okay, a lot fuzzy. And this is something that can go a long ways. Some research has already suggested that early uses of palliative care services can improve the quality of life. And in my life, it has really decreased anxiety, depression. I'm just in a much better place now that I take part in these services that are offered. And some of the services that I've enjoyed that our palliative care team offers would be yoga, massage therapy, counseling, healthy cooking demonstration. The list goes on, and I try to take part in as much as I can. Again, it has really helped in the quality of my life. Some of the experiences around pain management that I've experienced is I felt that I was actually given a medication for all of my complaints. As a metastatic breast cancer survivor, I've had a lot of things going on, and I've had a doctor or specialist for every bone in my body, trust me, from just the diagnosis itself, from the many places that it has spread. At one point, I know I was on at least 15 medications a day for things like blood clot in my lungs, pains and fractures, low blood counts. I literally was given a medication for everything that I complained about. And I end up taking some of them for just a few weeks because they were causing all kind of side effects like nausea, dizziness, hot flashes. And I was just drowning in hopelessly and depression. It was real until I consulted my palliative care team and got everything lined up. So the best thing that I can offer and suggest is advocate for yourself. I had to advocate for myself and my well-being. And trust me, I am in a much better shape than I was before. Now we would like to have Dr. Stephanie McCoy to introduce our guest speaker for today.
Thank you, Teresa, and thank you so much, Stephanie, for sharing your experience. We just want to make sure that everyone knows that we'll have an opportunity to ask more questions later on in today's webinar. So be thinking about those. You're also free to put those in the Q&A box. I have the honor of now introducing our guest speaker, Dr. Kimberly Curseen. Dr. Curseen is board certified in internal medicine, geriatrics, and palliative care. She is the Director of Supportive and Palliative Care Outpatient Services for Emory Healthcare, and she helps provide physical, emotional, and spiritual care for patients with cancer, while also assisting with complex decision-making at any point in individual's disease process. She's helped educate physicians on implicit bias in healthcare and has written research articles for the Journal of Palliative Medicine and the Journal of Pain Symptom Management on topics such as structural racism and bias in palliative care. I believe these articles and some other resources related to her work will be available after the webinar. Dr. Curseen has been named one of the palliative medicine inspirational leaders under 40 by the American Academy of Hospice and Palliative Medicine for 2014-2015. She has been consistently listed in Atlanta Magazine's annual Top Doctors issue since 2020. So again, welcome, Dr. Curseen, and thank you for joining us.
Thank you so much for having me. I'm really grateful, and Teresa, thank you so much for giving us a great headline. So I'm going to take the opportunity to share my screen. And I'd like just to take a sidebar to say, they say Mac computers are intuitive, and they should say they are intuitive to 7-year-olds, but not to 50-year-olds. So I just like to speak my truth. Are you all able to see my presentation?
We can, thank you.
Perfect. So I like to start with, I currently have no relevant financial disclosures, but I have 2 personal disclosures. My mother was diagnosed with hormone receptive breast cancer last month, and I also had a abnormal mammogram last month and waiting further testing. So I told my mom, "Hey, Mom, we're twins." She didn't find it as funny as I did. But I want to start with when we think about the scope of palliative care. So just like Teresa said, when you hear the term palliative care, that can be a little frightening and scary, because if you put it in the Google, you usually see palliative care and hospice together. So I want to sort of explain what we do, the scope of what supportive oncology is, talk some about pain, and talk some about the barriers so you can understand how best to advocate for yourself. So what palliative care is a specialized form of medical care focused on improving the quality of life with people who are living with serious illness, no matter where they are in that illness. The goal is to address the physical, emotional, social, and spiritual needs of patients and families. And the primary goal is the management and providing relief from pain, emotional stress, and other burdens associated with a disease. So when you sort of think about the scope of what we do, I say think of palliative care as a philosophy of care, where the focus is on you, the total person, versus the illness itself. We focus mainly on what is the illness doing to you and how is it affecting your ability to live your best life. And where we do start oftentimes when a person is diagnosed, we're with people while they're living with a serious illness, and for patients who their illness progresses in a way we don't hope, we're there with them at the very end. How this might be different if you hear the term supportive care or supportive oncology. Palliative care is a part of the supportive oncology. So when you think about all the things that you need to manage a serious illness, in addition to the symptoms, the nutrition, the finances, how do we afford this? How do I remain functional? Fortunately, if I'm able to move into a place of survivorship, how am I going to thrive? How all of this is going to work? So supportive oncology is that vital collection of services that people with cancer may need to support them throughout various stages. So say you may not need all of these things, but you will need some of these things at different times. And these are the kinds of services that should be available to you as a patient with cancer. And as Teresa pointed to, palliative care, supportive care, and advanced cancer is now the gold standard according to the ASCO guidelines. So any of you not familiar with ASCO, if you go to your oncologist and you realize there's a point in time where all the oncologists have gone, they're usually in Chicago at this huge meeting at the Academy Society for Cancer. And they put out the guidelines of how cancer treatment is standardized in this country. And they have said that palliative and supportive care should be available to patients to maximize quality of life through all phases of the illness. Palliative and supportive care is not equivalent to hospice care, and that hospice is the vehicle that delivers palliative care when a person's at the end of life. So this is really a standard of care. And I think many of you going through treatment have talked to your oncologist about what's the standard of care, what's the gold standard? Well, access to this care is part of the gold standard. And so when you're you're entering into palliative care, what is the philosophy? Well, we treat the symptoms as the primary focus. We're there to clarify what your goals are. And we sit in a place where evidence-based medicine sometimes fails. We are able to sort of sit in that place of uncertainty and help you work through that uncertainty. And why I think working through that uncertainty is really important is because when you're initially starting treatment, we're very directive about what you should do. Like there's not a lot of choice. Like we give you a choice, but not really. We're like, here are the list of things you can do, and this is what we really want you to do. And you get on our train and we start dragging you on our train. As things progress, you might notice that now you're getting more and more choices. Things are less and less certain. The odds and the numbers that they were giving you start to feel a little bit more squishy. You may find yourself in an area of uncertainty where you haven't been before, where even your providers are uncertain. And part of our job is to sort of help you walk through that, because we go from what's happening with your illness and how we're going to treat it to getting to a place where, okay, this has happened with your illness. How are you going to live with it? And what are the choices that you're going to make now? What are the benefits? What are the trade-offs? So the question that people will ask then, okay, great, this is a great service, but I have never in my life received palliative care. Why haven't they referred me to palliative care? So I say that if your oncologist or your oncology team, anyone on your team, your social worker, your nutritionist, your advanced practice provider, if they have ever treated your pain, if they had ever paused for a moment to create space for you to have an emotion or feel, they call to check on you, they help make sure that you have resources, then although they have not named it, what they have provided you with is primary palliative care. And that palliative care is care that's delivered through your treatment team. So I expect everybody has been given this type of palliative care. However, when those symptoms start to outpace, so as Teresa said, you start with one medication and the next thing you know, you're on 15 medications for symptoms and it's just a hot mess. When your symptoms start to outpace, that's when you need specialty palliative care. So that's when you might be referred to someone like me. So now this allows your oncology team really to focus on that cancer, while a team like ours focuses on you and managing all the things that are preventing you from receiving treatment or preventing you from having a quality of life. And that can be delivered in a clinic, and that can be delivered in home-based services. Many of our patients who live in rural America may not have access to a clinic, and so they're home palliative care. Sometimes people can get back and forth to treatment, but they can't handle multiple appointments. People who live hours and hours away can have palliative care provided in their home. And then many people who have been hospitalized may have received palliative care in the hospital from a hospital-based team. So basically, wherever you are, you can receive palliative care no matter where you are in the system. So what do patients with metastatic breast cancer and survivors actually need from palliative care? Well, I want to start with a detour. So this is going to be my soapbox, so please indulge me. No evidence of disease is one of the most ridiculous and insulting terms I have ever come across referring to a patient with cancer. That is actually insane. Like, what does no evidence of disease mean? If you have ever had a serious illness, there is evidence of disease all over your body, whether that disease remains active or not. So, and the reason why I want to put that in your mind is because when we're managing people who are living with their illness and people who have survived their illness for the rest of their lives, you will have evidence of disease. And when we say no evidence of disease, sometimes that implies that everything should be fine. And people who are living and survivors of cancer know that they're okay, but everything is not always fine. So the things that we like to think about is, how are we going to focus on that emotional support? You need us to do that. So having cancer is like a Mack truck running through your life, and you experience these emotional turmoil, depression, anxiety, and there's a significant amount of medical trauma. It's like getting cancer is like sometimes being dropped in the middle of a war zone, and nothing is in your control. It's all foreign. It's very loud. It's very fast. And everything comes to a screeching halt. That is incredibly traumatic. And we provide that psychological support to try to manage those complex emotions and help improve your ability to manage through treatment. And integrating mental health professionals into our teams is essentially for the emotional well-being. The other thing is, you want us to consider social determinants of health and structural determinants of health, because if you cannot physically get to your treatment, if you have children that have to be in school every day and you live several hours away, it's going to be really hard to participate in that clinical trial, which is requiring you to show up every day. And we sort of think about, what are the social economic factors that hit those barriers? The disparities in the palliative care utilization, how that exists among women from different racial and ethnic backgrounds and social economic status. And then we have to address these disparities and figure out ways to advocate so you can have equitable access. So I always laugh. I said, sometimes my job is not talking to people who want to stop treatment. Sometimes my job is to figure out, hey, how are you going to get to treatment? And how are we going to stay? How are we going to make this system more equitable and more fair for you? And we do that through our interprofessional teams. We also focus on symptoms. So if you don't feel good, it's going to be really hard to tolerate the things that we're asking you to do. So symptom management is one of the cornerstones of what we do. And those symptoms can include pain, fatigue, psychological distress, and effective symptom control improves quality of life and also reduces those hospitalization rates. I'm having trouble advancing the slide. So I figured we'd jump into a few common symptoms. So I figured, one of the things, we'll definitely talk about pain, but when I talk to women, what are the things that are sort of affecting them totally? Your vasomotor symptoms. So when we think about things like hot flashes and how that affects your life, I do want you to know that there is acupuncture or non-hormonal medications like Effexor or citalopram or Paxil or gabapentin. The reason why I bring these up to you is because the more you sort of understand about your symptoms, the more you learn, that allows you to make better and better choices. But these vasomotor symptoms are embarrassing. They interfere with your ability to have quality of life. Moving on to pain and something called total pain. So the way I sort of explain it to people, because sometimes they worry like, oh my gosh, I don't know why I have pain. Maybe the pain's in my head. Maybe I'm not coping. It can be really embarrassing talking about pain. We have criminalized treatments for pain. And so we've just made this incredibly difficult. So I say there's a physical part to the pain, but there's also a psychological part to the pain. So when you're hurting, you start to avoid activities. That makes sense. You get more deconditioned. The less conditioning you have, the less strong you are, the more the pain increases. You avoid the activity further, and then that just continues to create the cycle of pain. At the same time, you have the pain that is really frustrating. You start to get anxious, like, why do I have this pain? You're distressed. Sometimes you're angry. And then your mood starts to get low because you're living in that constant distress state. Depression starts. And when you have that impoverished mood and that depression, that increases your perception of pain. So I say these are like two gears. So if I just cut off the physical cycle, if I just cut that off, the psychological circle is going to continue to turn because they're interlocked. If I just treat the psychological symptoms and I don't actually treat your physical symptom, then this wheel is going to continue to turn and you're not going to feel better. So I explain to people that your pain is your pain. If you feel pain, you're not insane. It's not in your head. You're experiencing it. The driver may not be what we think it is, but the pain in itself is very real and debilitating. And what is causing the pain in patients with metastatic breast cancer and survivors? Well, several things. So research suggests that pain occurs in approximately 20 to 50% of cancer survivors. 30% of cancer survivors do not receive medication proportional to that pain intensity. And pain negatively affects the survivor's ability to function daily and the quality of life that can persist for years. So you've done all this, you've worked really hard, now you're a survivor, you're ready to live your life, and you're not able to do it because you're dealing with the effects of treatment. So where is this pain coming from? Post-surgery, post-mastectomy pain. So look, you have a mastectomy, things are going great. And then the lymphedema comes, and sometimes up to a year, or maybe even 18 months, you can develop post-mastectomy pain. The scar tissue changes. That's a really difficult pain. Of course, there's pain with chemotherapy from induced neuropathy. We all know about the aromatase inhibitors and the joint pain. I say it kind of gives you, I explain to patient, it gives you kind of like Nana and Papa body, like you go to get up and you realize, oh, I'm not quite there yet. Radiation necrosis, which doesn't happen right away. For any place that you get radiation, for some patients, the tissue can break down, the nerves can break down, cause tremendous pain. The weight gain that can come from some of the treatments, work hazards on our joints, and then of course the direct cancer pain. So I want to do a little detour and talk to you a little bit about opioids. And why I want to spend a little time here is because a medical system has not done a great job of sort of using these appropriately. And because we're in the middle of an opioid crisis, sometimes people who have pain or pain that we don't understand, we often make them feel criminalized, or if they've done something wrong, that it's the problems with them versus what's happening physiologically. So what we have noticed is that opioids can perform similarly to anti-inflammatories, medications called tricyclic antidepressants, anticonvulsants like gabapentin, can be similar and just as effective in helping neuropathic. Nociceptive pain just basically means the pain in the tissues. Central sensitization, the thing that kind of happens with your brain when you have chronic pain, your brain produces the sensations of chronic pain, and all the pains that are mixed, whether it's nerve pain or tissue pain. The problem with this is that opioids can perform similarly, and we're very good about thinking about the opioid-related side effects, but I would guarantee that non-steroidal anti-inflammatories, the Advil and Motrin, have side effects. Particularly as we get older, a lot of those anticonvulsants or these other antidepressant medications increase risk of falls and have tremendous side effects, and they do have withdrawal as well. So though we focus on that opioids aren't the best thing for patients who have chronic pain, when you have had a serious illness, and depending on your age and your organ function, sometimes this is actually the best thing. And we do acknowledge the risk of physical dependence, which is a side effect of the medication. Addiction is a possibility. Worsening, they can worsen depression, constipation, cognitive dysfunction, urinary retention. And then there's also a subset of opioids, particularly morphine, that have some immunosuppressive properties that can increase the risk of infection with people who are on immunomodulator therapies. So, these are the kinds of things that we really should be talking about, and when giving people choices about how to manage the pain. And we do know what the common side effects of opiates are: the dry mouth, the sleepiness, the depressed mood, the itching, the nausea, vomiting, the constipation. But there's also a set of side effects that people may not know about. So the increased risk of cardiovascular risk is equal to medications like Motrin, ibuprofen, naproxen, Celebrex. Certain opioids can interfere with the conduction of the heart based on their doses. Again, we talked about immunosuppression, and particularly for our gentlemen who have to be on opiates for a long term, or gentlemen with metastatic breast cancer, the opiates can decrease testosterone and increase the risk of hot flashes and cause sexual dysfunction, increase risk of metabolic syndrome, and osteoporosis long term. So I think when we're talking about pain and we are choosing what pain medication to take, it's really balancing those risks versus benefit. And that instead of explaining like, oh, we just don't want you on pain medications and it's time to come off, what we probably should be having is a conversation about risk risk versus benefit to allow you a choice, and also develop a plan about how we're going to address your pain in a multimodal way. We are using something called buprenorphine a lot more for pain. And, sometimes we'll have patients come in and we'll say, oh, we want to rotate you to buprenorphine. And they look it up and they realize, oh, that's Suboxone. And you think, and Suboxone is a medication you use for people who have opioid misuse disorder or addiction. And I want to always put this out here that the myths about this medication is that it doesn't control pain or that it's less potent and it's weaker. The truth about buprenorphine is it's probably the one opioid that we can prescribe that has the best side effect profile and the least likely to harm you. So it's very odd that we have set up in the system to stigmatize the one opioid that you're likely not to have terrible side effects from, because it does control pain. It decreases the endocrine risk, not the same risk of osteoporosis or cardiac illness. So I tell people that we spend a lot of time saying that we have some patients who are just going to have pain. They are going to need pain medication. And our goal, and what always our goal, is to get you to the safest regimen possible, the regimen that's going to provide you with the least amount of risk. The other thing I like to talk with you a little bit about is what are the messages that you guys are receiving at diagnosis or during treatment, and what is the unintended harm? So when you look at these, what are these saying to you, right? What do we say? Oh, you have breast cancer. Now I'm going to be a warrior and I'm going to be a fighter, and you're going to have to be resilient. And even if, under tremendous circumstances, you're strong and you never give up. The reason why we have these messages is to be inspiring, to try to help you push through this really difficult time, because the treatments can be really difficult. And we want to instill you with hope and fortify your strength. The problem with this is that how you move through this illness isn't quite like a warrior. Like, you're not going to feel strong every day. You're going to get tired. And I hate the term resilience, because resilience implies that something terrible can happen to you and you're going to come back just the way you did before, and maybe even better. No, if something happens to you, that a life-changing event, that fundamentally changes you for the rest of your life. So it's not that you should be resilient, but you have the ability to reform in a new way. So you're still yourself, but you're a different version of yourself after this. And when people talk about fighting or the warrior, then they say, oh, they lost their battle with cancer as though they did something wrong. Well, no, you didn't do anything wrong. You didn't do anything wrong. So I like to think that you have this illness, and the strength is to deal with what is coming. But no matter what happens, that's not a deficit within you. And that's with people going through treatment. But that's also, I want to make that with our survivors. The fact that you may not be quite 100%, or that you're still tired, or that you're still struggling with pain. You're still managing fatigue. You're still trying to psychologically sort of sort what has happened to you is okay. And that's perfectly fine. And we should be supporting you through that, but not judging you through that. And we don't want you to judge yourselves. Because what does an illness threaten? It threatens security, certainty, confidence. It takes your confidence, stability, and well-being. And I often, I have patients describe it, but when they're talking about this, and it's like a betrayal, like the most important person in your life has betrayed you. And they look at me like, what do you mean? I said, well, your mind and your body had some plan. Your mind and your body had an agreement about what you were going to do, about what your life was going to be like. And then all of a sudden, unbeknownst to you, your body decides to do something completely different. Your body decides to get sick. And that means that even if the threatening illness is no longer active, how do you trust your body now to make plans? How do you trust your body and a mind to be aligned? That's a betrayal, and it takes a while to develop a sense of security. And when you have had a serious illness, you will always live with a little uncertainty. You see mortality in a completely different way. Like we all know that terrible things can happen to us. We also know that we will all die one day. But when you have a serious illness, you know that on a different level. And that changes you. It changes the way you make decisions. Sometimes it even changes the way you see the world. And for some people, it actually can improve, like people have found going through their serious illness, and they'll describe it, looking back on it as, hey, this is the thing that made me the person I am today. But others, it takes them a minute to kind of get there, and we need to be able to make room for that. The other thing that affects is something called demoralization. So demoralization is a syndrome that affects cancer patients, other people with serious illness, but it's characterized as these feelings of hopelessness, despair, and inability to cope. And it's a significant problem in oncology, and it shows that studies report that maybe 36 to 52% of cancer patients experience demoralization. And when you have demoralization, it's linked to negative outcomes, which means you're feeling your pain worse, the symptoms are worse, the quality of life is worse, and the thoughts of the risk of suicidality is higher. So how is demoralization different than depression? So when you have depression, you have feelings of hopelessness, you have a hard time, getting motivated, you may withdraw socially. And oftentimes when you're depressed, people can see the depression on you. They can see it. And then you have sleep disturbances, appetite, all of that. When you are demoralized, that's something different. That's not something chemically happening in your body that can just be fixed with a medication, right? Demoralization, you can be going to work, raising your kids, doing being superwoman, superman, but on the inside, you feel helpless. On the inside, you don't see a purpose in the things that you saw purpose before. You feel loss of control. You're finding that maybe your personality has changed. You're not adapting in the same way. And people may not even really notice, but that demoralization really affects long-term how you experience, and incredibly important to treat, and often in palliative care places and teams we do. So how do we do that? Well, double therapy. So sometimes say people, oh gosh, why do you want to send me to therapy? How is talking about something going to help? And I'm like, you're right. Talking about something is probably not going to help because you already know what's wrong. The problem is you don't know what to do about it. So the psychological therapies that you may get offered within palliative care may be cognitive behavioral therapy to sort of help you figure out, how do you manage the pain? How do you manage your mind with the pain? Acceptance and commitment, helping you figure out how to accept what's happening, but not have it control you, understanding the experience of suffering, but figuring out now how to accept that, and then what do I commit to get to my best life. And then also, if you're experiencing PTSD, where you walk by, you look at your cancer center on the television screen, or you see like a Kisqali commercial and you start having palpitations, you're having PTSD like a soldier, and that is completely different therapy and needs special attention. Also thinking about complementary or integrative medicines. So some palliative care services are able to provide integrated therapies, which can be incredibly helpful for pain. Others have their integrative services separate. But I do want you to sort of think about that as not a replacement for your regular treatment, but as something to supplement. And when you are engaging in these therapies, this is something that you're able to control and to contribute to your care. So what are some of the barriers? I want to make sure we have more time for discussion. But the barriers to getting to seeing people like me are the misconceptions that if you go to palliative care, it means that you have to end curative treatment. And I explain to people that palliative care is not hospice. Hospice is a type of palliative care that people receive at the end of life because they need that aggressive medical support. Hospice is an insurance benefit that provides the most support and the aggressive medical and social support people need when they're in that phase of life. But palliative care itself can be delivered early through offices, through the hospital, through home, and also through hospice, but not all palliative care is hospice care. It's important that we educate people on the compatibility of hospice care with active treatment. And so Get Palliative Care is a really great resource. What are some of the concerns that your doctors have? Healthcare providers may be reluctant to introduce palliative care early because they worry that we are going to take away hope. So the same misconceptions that patients have, the same misconceptions your providers have. And the other thing too, you know what, look, palliative, doctors aren't magical. The white coat doesn't make us magical. And those relationships that you have with your oncology team are very intimate. So when you ask to bring us in, sometimes they have feelings about that. They're like, hey, we're doing a good job. Don't you think we have something good going? Why are you bringing this other person into your team? So sometimes that's the reluctance. So when we think about embedding palliative care teams within oncology teams, really helps address these concerns because now we're working more. So this is the reason why having integrative clinics are better. What are some of the disparities? Well, there are significant disparities in access. So I can say like, hey, this palliative care is great. And everybody's like, yeah, I want palliative care. And they're like, where can I get palliative care? And we're like, well, it's not in your community. So we have to really work on thinking about, and what we ask for organizations like this to advocate for is to advocate for palliative care programs, whether they be in the communities, whether they be in their clinics, because when you all ask for that, that's what moves the needle. And we know that racial and ethnic minorities with metastatic breast cancer still receive significantly less palliative care than non-Hispanic white women. And obviously, it definitely plays a role thinking about what policymakers are sort of understanding that there are Medicaid, there are two states, Hawaii and California, have actually added palliative care as a service that patients must have and be offered as part of the insurance program. That comes from the legislatures thought it was a good idea, but that came from a lot of advocacy, not just from the doctors, but also from the patient. And understanding that fewer than 25% of women with metastatic breast cancer receive palliative care between 2010 and 2017. So in my last minute here, I want to give you a call of action: the access to high quality palliative care delivered by an interprofessional team, which is the doctors, the nurses, spiritual health clinicians, the social workers, and other people that we may have, is standard of care. Primary palliative care delivered by your oncology teams is essential. And so if you're doing great with them and they're doing right by you, you are getting good palliative care. And accepting palliative care is not giving up, has nothing to do with what's happening to you, because palliative care is going to support you through your goal. We as healthcare providers should fight just as hard for our patients' quality of life as we fight for your access to treatment and cure. And I would also say this about the organizations that you are joining: as much as we are advocating for trials and all these other things, we need to advocate not for how we are going to manage your illness. We need to advocate for how you are going to live with the illness just as hard. And then no evidence of disease is a ridiculous statement, has no real meaning, because cancer is not over when the scans are clear, because you have a whole other journey that waits. So I'll go ahead and stop here, but I really appreciate the time.
Thank you so much, Dr. Christine, and thank you so much for Stephanie and to Lisa for this whole conversation. It's been so helpful. We have an opportunity to continue the conversation. If you would like to ask any questions, the Q&A box is still open. We have some pre-submitted questions and one right now from the Q&A box, and I will read this first question. I think this one is for you, Dr. Curseen. If you are between treatments and not sure if you want to go to a second opinion, would a palliative care person be able to help you with that decision?
The answer is yes. So how do we help? Number one, we are going to be supportive. So I tell people it can be hard to go to your oncologist. So I say, go ahead and pitch it to us first. But I think what we provide, number one, is validation. That is very common for patients with cancer to move about the country. Your oncologists sort of expect that. The other thing is we can also help you with expectations, because sometimes you get a recommendation from your oncology team. And so the idea, the way TV makes it sound is if you go across the country, they're going to say something different. They're going to have something better. And sometimes they do, but sometimes they don't. And that is really painful and it can be disappointing. And sometimes their communication of that can be a little rough, not what you're expecting. So I think I like to spend time sort of preparing people for the things that they may hear, and want to make sure that they can reach out to us if they hear something that they may not quite understand, hear something that is not as hopeful as they're hoping for, to be able to help explain that. But I do also want to make sure that they have that support to seek that second opinion and feel like it's okay, and that we are always here to come back to.
Thank you. Another question, how can we ask for palliative care and where can I get information about what it entails?
I would direct you for the information to getpalliativecare.org. Like if you just put get palliative care, and that was in the slides, that gives you a really good synopsis. And it actually even has a place where you can put in your zip code and you can see providers within your state. But I think that 10 years ago, you could go maybe to your oncologist and maybe 50-50, if you asked for palliative care, they would say yes. And then other 50% would get pushed back. Nowadays, because times change, or new oncologists have had this training, they see the benefit of it, ASCO has blessed it, then I think you will get a pretty positive response. However, this is how you start the conversation. Hey, doctor, I think I would like to have, I think I need to see palliative care. I am not giving up. I just need extra support through my journey, right? Because if their concern is that you're going to give up or that you may consider taking a different treatment road than they have planned for you, you want to be able to reassure them that this is not a deficit in them. You're not going to do something without them, but you need this. Like they're great, but you just need a little bit more. And most of the time people understand that.
I have a question. That's a Stephanie. Sorry, trying to get over a cold. And it was one of our pre-submitted questions, but I'm really wanted to hear this response. Does pain show up differently or occur at higher rates for Black patients undergoing treatment than white patients? The
No.
misnomer that we have, that's out there, that we tolerate pain better, and I know we don't, but
we do not. We do not. That is a myth. We are not a different species. We are a human. We are 99% similar. And if you do your genetics, you might find that you're more similar to other people than you think. Yeah, the amount of melanin does not change the amount of pain that you feel. Nope, feel the same way.
okay, I'm gonna get you to say that a couple more times, and then I'm gonna blast it all over the world.
Yes, this is not magical. Yeah, this is not a pain shield.
Kind of related to that, Dr. Curseen, this was also a previously submitted question. Is there anything a white patient can do to advocate for addressing the typically undertreated pain of Black patients?
That's a really good question. I think the best that you can do is within your support groups. Like I find the support groups to be very segregated and for a variety of reasons, because there are in different communities, but I think bringing people of different ethnicities together with different life experiences changes the way you think and humanizes that person. So when you see somebody as a human, then it makes it easier to advocate. So I think belonging to organizations, your national organizations, your patient organizations, but every once in a while, if you have a community getting together, really helps. Because if you want to advocate for somebody, you first got to know those people that you're advocating for. You got to have that conversation. And that actually goes both ways, because you'd be surprised that our white patients and our Black patients are often in the same boat. Boat's a little different, but you both are probably not getting the things that you need from the healthcare system.
I had a question, Dr. Curseen. You mentioned going to seeking out palliativecare.org, but there are those patients, even de novo diagnosed, they don't know about, palliative care, whatever. And going back to what I had mentioned earlier, why isn't the normal thing is for the oncologist or the healthcare team to mention that up front and to give some type of information on that so that we can act accordingly?
That's a good question, because we're behind. We're behind. Like we know, like this is the standard of care, but just like anything, it's like a cruise ship, that it still takes a while for all people to catch on. The other thing is we don't have equal access. So if we, it's like offering you this jewel or this food, somebody offers you some food and then they tell you, oh yeah, by the way, we don't actually have the food here. Then, what do you do with that? So I think that we can say it and the doctors can say it and the research can say it and the organizations can say it. What moves things in this country is the consumer. So you all demanding it and mentioning it and becoming educated about it is going to be the way we sort of change things. And that has been, in time. And using the platforms like these are really helpful. Going to places where people have less, whether you talk about this in churches, whether you talk about this at family reunions, but being in those spaces, when you hear somebody talk about palliative care or that they have cancer and you say, hey, what about this? And they're like, no, it's hospice. You're like, no, it isn't. Like we need people who look like us to say that to us. Right. So that's going to be really, really important. And that's just not racial ethnicity. Hey, I'm down south. And you'd be surprised, it's not that much different, but we need people to say it to us and then we need to demand it.
We have a question, but I think one of the comments in our Q&A box kind of explains the question. The question is, can you explain the second half of the sentence in your slides when you were talking about no evidence of disease? I think it said something else is awaiting. What does this mean? But one of the comments says, I agree with your response to Ned. My body is full of evidence of disease. So I think that kind of relates, but if you want to expand on that, feel free, Dr. Curseen.
I think the comment was perfect. Sometimes we use no evidence of disease. So if we have survivors out there and you come with a symptom, you're like, my joints are still achy. And they first start with, well, you have no evidence of disease. So you must go see your primary care doctor. And you go to your primary care doctor and they're like, you don't have cancer anymore. Are you asking for pain medication? Like, no. So I think that we sometimes use no evidence of disease as a way to justify not taking your symptoms seriously. And the reason why we're doing that is because we don't know what to do. So we could say, gosh, you're experiencing this, I don't know how to help. Maybe I can find somebody to help you help. That would be a logical way to handle it, but we don't handle it that way. And the no evidence of disease is a way of gaslight. I feel like it's gaslighting and telling people in a way, or telling you in a way that, oh, well, the cancer's over, so you should be fine. But the truth is, the only thing treatment can offer you is an opportunity at physical life. It does not offer, it cannot give you quality of life. It's just saying, I'm going to treat you and you can survive. So you got that. Now, to get to wellness is a completely different thing. So there's this whole other mountain that you have to climb. You get the mountain of treatment and cancer and you ring the bell, yes, but you're not done. You're not done. There's a whole other mountain. And that's when we abandon you. That's when you're Sherpa Lee. Like, here, we're halfway up Mount Everest, and now I'm going to go and let you get to the summit by yourself. That's insane. So I think I need us to recognize that, that's all treatment has to offer. You getting to wellness is something different. And that's going to take a minute, and that's going to take some help.
Thank you. This is so helpful. And it's really resonating. We got a comment. This person said, exactly, I'm at this point and confused. I'm anxious about the scans being incorrect. And I think this is just really resonating with everyone. We really appreciate everyone for your time. This has been an incredible webinar. As a reminder, please answer the post-webinar survey, which can be found. I believe we're going to email it to everyone who is listed as an attendee. This is the last webinar of 2024, so all webinars are on the website at nbcalliance.org/speaker series. We hope you all have a safe fall and winter holiday season, and we'll look forward to seeing you all in 2025.